Good day, everyone. My name is Adam Arndt. Today's lecture will cover the induction of general anesthesia and can generally be considered as an introduction to anesthesiology as a clinical subject. This presentation is quite extensive and includes many aspects related to general anesthesia, as well as anesthesia in general as subject, and of course the preparation to general anesthesia. On this slide, I present a detailed outline of this presentation, which is divided into major topics and separated subtopics. First, there will be an introduction, followed by premedication, sedative drugs, antimimetic drugs, secretion inhibition, aspiration prophylaxis, and optimization of volemy. The next major topic will be pre-anesthesia, where we will focus on preparation for anesthesia. This process is essentially the same for other types of anesthesia. However, it is also necessary to perform it before the induction of general anesthesia. This includes the anesthesiology machine, monitoring, emergency drugs, and tools. These are the topics we will cover in this section. The next part is the induction of general anesthesia itself, which is perhaps the most important point of this presentation. This includes pre-oxygenation, rapid sequence induction, opioids, intravenous anesthetics, binding agents, intubation, and initial ventilator setting, as well as the ventilator and anesthetic gases. Here will be a brief overview of these initial settings, which often present many difficulties for you. To talk about anesthesia, it is essential to distinguish the individual components of general anesthesia. When we ensure that all elements occur, we will be talking about so-called general anesthesia. Among these components, the primary ones are the abolition of consciousness, pain relief, muscle relaxation, and elimination of reflexes. One by one. The abolition of consciousness can vary in degree. It can be either partial, which we will call light sedation, or complete anesthesia if patient is totally unconscious. In the case of general anesthesia, we are dealing with global pain relief. However, this can also be achieved through segmental pain relief, such as regional anesthesia. An important component of pain blocking is also the blocking of adrenergic reflexes, because, as you know, pain activates the circulatory system by increasing blood pressure and heart rate. Another component of reflex inhibition is muscle relaxation, which is particularly important during surgical procedures. This involves both consciousness response and reflex reactions to pain. The last component is areflexia. As you can see, the final points overlap significantly. One of the most important aspects seems to be the classification of anesthesia. Anesthesia can be divided into general anesthesia, regional anesthesia, local anesthesia. In general anesthesia, there is a depression of central nervous system to varying degrees. One can distinguish procedural sedation or analogous sedation. With increasing depression of central nervous system, this sedation approaches the state of general anesthesia. Procedural sedation is used in the West even by doctors of other specialties for less painful procedures, such as gastroscopy or colonoscopy. Analogous sedation, when there is complete pain relief and total abolition of consciousness, can even be considered as full general anesthesia. Regional and local anesthesia are characterized by blocking nerve conduction. In regional anesthesia, more nerve fibers are blocked, than in local anesthesia. In regional anesthesia, we primarily distinguish central blocks, which is in Polish can be called paraspinal anesthesia, including subarachnoid anesthesia and epidural anesthesia. We can also distinguish nerve blocks when we anesthetize a specific nerve, but its effect is distal to the site of local anesthetic injection. We talk about plexus anesthesia when several nerves are anesthetized at once, which usually result in a wider area of anesthesia than with nerve blocks. Local anesthesia refers to anesthetizing the area directly, subjected to painful stimuli, such as infiltration anesthesia, commonly used for suturing small wounds, also known as infiltration anesthesia. The last type of anesthesia is so-called surface anesthesia, applied to various creams, ointments, and pads. When we using local anesthetics, as I mentioned in previous slide, one type of anesthesia is central block, primarily subarachnoid and epidural anesthesia. Since we are talking mainly about general anesthesia, it is particularly worth noting that epidural anesthesia is often combined with general anesthesia. Together, they have great synergistic effect in terms of analgesia, such as epidural anesthesia combined with general anesthesia can often be observed during liver and upper abdominal surgery in our practice. A particular advantage of this type of anesthesia is that the catheter left in the epidural space remains after surgery, providing the possibility of forced continued pain management postoperatively, which means good postoperative pain control. Another noteworthy anesthesia is plexus blocks. Among these, the brachial plexus block plays a special role. This block can be performed from one of four approaches: interscalene, supraclavicular, infraclavicular, and axillary. Depending on the approach chosen, either the rods, trunk, or branches of the nerves are blocked. Naturally, the area affected by the anesthesia is quite large, usually the entire upper limb. Depending on the chosen approach, the anesthetized region will vary. One example of peripheral nerve anesthesia is nerve block anesthesia. This is particularly common in dentistry. As you can see in this diagram, the inferior maxillary nerve is blocked. This type of anesthesia is typically chosen when infiltration anesthesia is impossible or very technically difficult. The principle is that the local anesthetic is administered to a different location than where the painful stimuli will act. In contrast, infiltration anesthesia involves administering the local anesthetic directly to the area where the painful stimuli will act. This is also frequently used by dentists, but in the upper part of the jaw. Of course, this type of anesthesia is also widely used for suturing small wounds or minor procedures. It is also used in anesthesiology before central blocks to anesthetize the skin before inserting typically larger needles into the paraspinal area. Surface anesthesia also plays a significant role. It involves applying the appropriate pharmacological agent directly to surface, which can be the skin or more commonly a mucous membrane. This is likely familiar to you with xylocaine. Xylocaine is essentially a lidocaine at the higher percent concentration, which allow for mucous membrane anesthesia. It is popular choice before procedures. Procedures like bronchoscopy or gastroscopy. In anesthesiology, xylocaine is also used when performed awake intubation. By this, I mean the situation when we intubate a conscious patient. This is sometimes done if we anticipate difficult airways. Another interesting preparation is ethyl chloride. This agent owes its anesthetic properties to the fact that it cools the tissues to which it is applied, resulting in local anesthesia. However, it should be noted that this preparation has carcinogenic properties. Despite this, it is often used for minor procedures. The last agent worth mentioning for surface anesthesia is emlapates. Uh, these are pharmacological agents combining lidocaine and prilocaine. They are most commonly used in pediatric anesthesiology. When do we want to protect our minor patient from the pain associated with injections? Let's move on to general anesthesia. Like a good essay, it has an introduction, development, and conclusion. Of course, the phases occur differently. These are induction, maintenance, and emergence. During different phases, the anesthesiologist has various tasks. The most time-consuming and risky phase for the patient is the induction phase. During the maintenance phase, if the induction was performed correctly and we are prepared for various events during the surgical procedure, it is essential to remain vigilant and pay particular attention to maintain appropriate, meaning adequate, anesthesia and analgesia. Regarding emergence, it is worth noting that it is not, as many patients believe, that the anesthesiologist administers some medication that wake the patient up. It is all based on pharmacodynamics. Appropriate medication have a specific duration of action. Experienced anesthesiologists can select them in such way that they case end their effect when it is time to wake the patient. This belief probably dates back to historical times when long-acting anesthetic drugs were used. At the first time, it was indeed often necessary to administer medication that had a stimulating effect on the central nervous system to reverse their effect. However, this practice now has been abandoned. We distinguish three primary types of general anesthesia. The first is intravenous induction of and maintenance, known as TIVA. This is probably one of the favorite questions in class and on our exam. The question is, what is TIVA? As already mentioned, we use only intravenous agents. In sense, it is a special type of anesthesia. Currently, intravenous induction and inhalation maintenance dominate, especially preferred in adults. So, the second point of this slide is the most commonly used. Please remember this. This is because during most procedures in which you will participate in, the patient sleep no because of intravenous anesthetic agent, but thanks to anesthetic gases, primarily sevoflurane and desflurane. The last type is inhalation induction and inhalation maintenance. This means that sleep, or rather the depression of the central nervous system, is fully attributed to our anesthetic gases. This type of anesthesia is particularly common in children. However, it carries risks, and it is not very widely used. Let's move on the next part of the presentation. As you saw, the introduction is complete. Let's move on to premedication. I also mean the premedication visit. The premedication visit includes an initial anesthesiological assessment. Besides this initial anesthesiological assessment, it is also necessary to obtain informed consent for the procedure and choose the optimal approach. This largely depends on patient condition and what is best for them at this certain moment. To properly assess the patient, knowledge of several scales is essential. The scales mentioned here do not X out all the scales used in anesthesiology. However, they are the most important ones, and please familiarize yourself with them and expand your knowledge about them from appropriate textbooks. The ASA scale seems to be the basic scale in the anesthesiology. It is a scale developed by American Society of Anesthesiology. It is a 6-point scale where 1 indicates completely healthy patient and 6 indicates a patient with brain death. Another scale used in anesthesiological assessment is the Apfel scale. On the right side of the slide, we can see risk factors for postoperative nausea and vomiting listed. This is what the scale concerns, as well as the corresponding frequency depending on the number of points from this risk. How many we obtained? Currently, adequate prophylaxis for postoperative nausea and vomiting is possible. It should be carried out both pharmacologically and non-pharmacologically through appropriate procedure selection. Pay particular attention to so-called multimodal anesthesia, which involves the use of various drugs to protect the patient from pain because using only opioids requires administering them in higher dose, and this significantly increases the risk of postoperative nausea. Another basic scale you should know is the Malampati scale. One of the greatest difficulties that can occur during the anesthesia of patient is inability to intubate them. We are dealing with so-called unexpected intubation. This is a life-threatening condition for our patient because sometimes when the patient is relaxed, the muscles of the patient are relaxed and we cannot properly ventilate them. It can lead to hypoxia and secondary cardiac arrest. The Malampati scale actually assesses how much of the soft plated we can see. In grades 1 and 2, we see the platal arch and the base of the uvula. In grades 3 and 4, this visibility is significantly reduced, as you can see in the picture. Grades 3 and 4 indicates that we can expect difficult intubation. As you can see in grade 4, the platal arch are no longer visible. Please also remember that this examination is performed with the patient sitting, so asking the patient to fully open their mouth while lying down is always reliable, not accurate. In addition to assessing the patient and choosing the correct anesthetic procedure for them, of course, we have to obtain the agreement for the procedure. The anesthesiologist also usually orders premedication. Premedication is primarily associated with the administration of some pharmacological agents, but not exclusively. It should be remembered that anti-anxiety effect can also be achieved through appropriate conversation with the patient, calming them and assuring them of the procedures to be performed. This is also an element of premedication, but currently premedication is primarily focused on pharmacological action, which we will achieve with appropriate agents. This slide lists the basic principles of premedication, which include reducing anxiety, reducing pain, reducing secretion, prophylaxis of vomiting, aspiration prophylaxis, antibiotic prophylaxis, and regulation of underlying condition. Reducing patient anxiety is particularly important because it allows for a reduction in the amount of medication that we use during the induction of general anesthesia, thus decreasing number of complications, as smaller doses mean fewer complications. Pain reduction. Pain is often a source of non-cooperation from the patient, and of course anxiety, as mentioned earlier. If dealing with a medical condition that can cause severe pain, it is advisable to prescribe a painkiller as part of premedication, adjusted according to the type and intensity of the pain. Reduction of secretion. This is particularly important in ophthalmology and otolaryngology. However, it is also important to consider reducing secretion in pediatric patients who often react by crying after being separated from their parents. This is determinable both for the anesthesiologist and the patient, as the secretion collected in the upper and lower throat obstruct the anesthesiologist and pose a risk of aspiration into the bronchial tree, which is also dangerous for the patient. Therefore, it is important to consider reducing secretion in such patients as a part of premedication. Vomiting prophylaxis. This primarily refers to the prevention of postoperative nausea and vomiting, which can be achieved through appropriate premedication and use of suitable agents. Aspiration prophylaxis is also crucial to prevent the unwanted entry of stomach contents into the respiratory tract, which can cause Mendelssohn syndrome and acute pneumonia with seriously negative prognosis. Preoperative antibiotics prophylaxis is also used. I hope it is obvious to you that bacteria can be present on our skin, which during surgery can cause significant complications. These include wound healing disorders, sepsis, and potentially even septic shock, as well as the regulation of underlying condition. This is also an element of premedication. However, it is such an extensive topic that I will not discuss in detail here. Generally, if patient is on chronic medication, this medication should be continued in the same doses and at the same times as before. However, some medication can negatively affect the course of anesthesia, especially diuretics. Therefore, they should be discontinued on the day of the procedure. In general, efforts are also made to reduce the number of tables before anesthesia as part of aspiration prophylaxis. Sedative medication play an important role in pharmacological premedication. The first-line drugs are benzodiazepines such as midazolam, lorazepam, flutrinazepam, diazepam, and clonazepam. In Poland, midazolam is the most commonly encountered. Remember, benzodiazepines are positively allosteric modulators of GABAergic receptors, thus exerting the depressive effects on the central nervous system. Besides their sedative and calming effect, they can cause amnesia, which is particularly important for premedication. Antihistamines, such as hydroxyzine, are also used. However, it should be remembered that hydroxyzine can increase the risk of persistent postoperative pain, so it is not commonly used. Of course, there are situations where this medication is necessary. Theoretically, neuroleptics can also be used in premedication. Promethazine and phenothiazine occupies an important place here due to its sedative and antimimetic effect. Magnesium also has a role in pharmacological premedication due to its negative inotropic effect and its sedative, stabilizing effect on the circulatory system. It also stimulates NMDA receptors, similarly to ketamine, which is an important element of multimodal anesthesia. Lidocaine, besides being a local anesthetic, can also be administered intravenously. In this form, it is primarily used to provide adequate neuroprotection. Clonidine also has a place in premedication. Although it has a strong hypotensive effect, its alpha-2 adrenergic receptor agonism can also induce a sedative effect. However, it is important to note the significant hypotension associated with this agent. The most commonly used benzodiazepine in Poland is midazolam. Please remember that these are the blue tablets, and it is also comes in an intravenous form. Dormicum and midanium are both midazolam. It is particularly popular in anesthesiology due to its relatively short duration of action, which can vary between individuals from 1 to 6 hours. This maximum effect after oral administration is reached after about 30 minutes to an hour. However, when administered intravenously, the effect is almost immediate with midazolam. Special attention should be paid to the first pass effect, as oral doses are much higher than intravenous doses. Another important point to consider when using this medication is that it is metabolized by CYP3A4, leading to unwanted pharmacological interaction with many drugs, which can prolong its action. Magnesium has a carved out of special role in anesthesiology. It is a drug for many emergency situations, significantly improving the condition of the bronchial tree through its broad dilatation. It has a positive effect on many arrhythmias, helping to suppress them. It has hypotensive effect on circulatory system, but it can also influence NMDA receptors and thus has some analgesic properties. Hydroxyzine is also used to treat preoperative anxiety. It is particularly popular among elderly or obese patients, for whom the use of benzodiazepines pose a special risk of perioperative apnea, when they might not yet be monitored. Hydroxyzine can also have a depressive effect on the respiratory system, but it is much less pronounced than with benzodiazepines. Hydroxyzine exerts its unique anxiolytic effect as an antihistamine and as serotonin receptor blockers. This allows it to be classified as an atypical neuroleptic. It should be particularly noted that this medication can block the supraspinal effect of NSAIDs, potentially contributing to persistent postoperative pain. Blocking serotonin receptors can also prolong the QT interval, which may be dangerous for the patient with arrhythmias. Promethazine is not frequently used nowadays. However, it is noteworthy medication to remember. Like hydroxyzine, it can cause persistent postoperative pain. It can also cause extrapyramidal symptoms. It is important to be aware of significant intraoperative hypotension associated with its use in premedication. Lidocaine is primarily a local anesthetic. When administered intravenously, it has many important effects. It primarily tones the circulatory system and has a sedative effect. However, it should be noted that while it has a significant neuroprotective effects in excession doses, like any local anesthetic, it can be cardio, on, and myotoxic. Therefore, we have to use it carefully. Clonidine, as I mentioned earlier, is an alpha-2 receptor agonist. It is a drug particularly often used in functional endoscopic sinus surgery. This is a procedure where we want to maintain low blood pressure. In most surgical procedures, low blood pressure and intraoperative hypotension are avoided. Antimimetic drugs used in premedication, primarily for prophylaxis of postoperative nausea and vomiting. The serotonin agonists, also known as sertrons, play a special role here. These include ondansetron, granisetron, and palonsetron. The NK receptor agonist with apregrant currently leading the way, also significant. Until now, ondansetron and aprepitant might be familiar to you primarily from the treatment of nausea and vomiting associated with chemotherapy. I want to point out that they are also particularly popular and frequently used in anesthesiology. Dexamethasone. Yes, this steroid is also used for prophylaxis of postoperative vomiting. There are also antihistamines like dimenhydrant and cyclizine, the butopropion, droperidol, and scopolamine. These are not very commonly used in premedication nowadays. When discussing the prophylaxis and treatment of postoperative nausea and vomiting, special attention should be given to aprepitant and dexamethasone. These two drugs can only be used for prevention. This means that a decision must be made before induction that we want to implement such prophylaxis for our patient. As you know, dexamethasone carries significant complications, and very often the anesthesiologist must forego commonly used painkillers like NSAIDs. Other drugs can be used for both prophylaxis and treatment of nausea and vomiting. Ondansetron. As I mentioned, it can be used for both prophylaxis and treatment of nausea and vomiting. It should be noted that it primarily has a stronger effect in preventing vomiting and lesser effect on nausea. Therefore, the patient might still feel nausea despite using this medication. Similarly, this drug can be used both for prevention and treatment, but the dosing differs. For prophylaxis, 4 mg should be used, while for treating vomiting that has already occurred, 1 mg should be administered to achieve a satisfactory effect. It should also be remembered that ondansetron in rare cases increases the risk of prolonged QT interval, and should also be noted that this drug antagonizes the serotonin receptors. This receptor is utilized by tramadol for pain treatment. Therefore, combining ondansetron with tramadol is not very beneficial as it is significantly reduces the analgesic effect of tramadol. Aprepitant was previously used mainly to prophylaxis of chemotherapeutic induced nausea and recently it has also been used for the treatment of postoperative nausea and vomiting. This is a relatively expensive drug, but it exerts its direct effect on the NK receptor, stimulated by substance P, which is directly involved as a chemoreceptor in inducing vomiting. As I mentioned earlier, dexamethasone is used exclusively for prophylaxis. The exact mechanism of its action is not well understood. It should be noted that the doses used in premedication are lower than in regular treatment, being around 4 milligrams for premedication. It is popular because it is lack of mineralocorticoid activity, meaning it does not distribute electrolyte balance in the body while exerting its effect as glucocorticosteroid. Therefore, it also carries the significant risk of upper gastrointestinal bleeding, especially if combined with NSAIDs. Dimenhydrant, commonly known as Dramin, is not widely used in Poland in anesthesiology, but it is particularly popular across our western border. It should be noted that it also has antiemetic agents, also a sedative effect, of course. Droperidol, a butyrophenon similar to haloperidol, has antiemetic properties, but this neuroleptic was chosen to perioperative management. Currently, it is not widely used drug. It is almost unavailable or very rarely used. Droperidol has a significant advantage over haloperidol because it acts much shorter. It can induce neuroleptoanalgesia. This is a historical term when patients were anesthetized by combining fentanyl, a strong opioid, with droperidol, creating neuroleptoanalgesia that allowed for most surgical procedures. It should also be remembered that as neuroleptic, it can prolong the QT interval and cause arrhythmia. Scopolamine. In Poland, it is currently only available as a patch, especially scopolamine hydrobromide. There is also scopolamine butylohydramide, known as Buscopan, which is noteworthy because it is available in Poland. However, the dosing is much higher, as scopolamine hydrobromide used in anesthesiology is dose 0,3 to 0,6 milligrams. In contrast, scopolamine butylobromide, commonly known as Buscopan, is often associated with antispasmodic effect and is administered in much larger doses of 20 milligrams. I hope this does not confuse you. Scopolamine hydrobromide can cross the blood-brain barrier, exerting a central effect. It is scopolamine that has a strong antiemetic effect. Antimuscarinic drugs. These are also used in premedication, although they are primarily associated with emergency medication. As you probably remember from pharmacology and physiology, they inhibit the parasympathetic nervous system. This means they effectively promote the activity of sympathetic nervous system. Their inhibitory effect is primarily on M1 to M3 receptors. M1 and M3 are found in the bronchi and salivary glands. Under normal conditions, stimulating these receptors cause bronchoconstriction and increased secretion. Therefore, when we have an antimuscarinic effect, we will see bronchodilation and secretion inhibition. Through their effect on the heart, we'll observe an increase in heart rate, which is particularly important during anesthesia, especially during general anesthesia when we may face life-threatening bradyarrhythmia. There are three antimuscarinic drugs: atropine, glycopyrrolate, and scopolamine. In Poland, atropine is the most widely used. Atropine has the strongest effect on the heart and crosses the blood-brain barrier, exerting a central effect. In a sense, it has a stimulating effect, while glycopyrrolate does not cross the barrier. Scopolamine also crosses the barrier to some extent, providing sedative and antimimetic effects. On the next slide, you see a preparation with atropine. It is quite characteristic. A syringe with atropine is always prepared for every general anesthesia, and internally we have an agreement that it always contains 1 milligram atropine in total, as it is diluted this way. 0.5 milligram, half milligram is in 1 milliliter. 0.5 mg in 1 milliliter. The standard dosage for an adult in severe bradycardia is 0.3 to 0.6. It is an emergency medication, important to remember. I do not have personal experience with glycopyrrolate. However, it is a drug worth knowing about for tests and exams. Regarding aspiration prophylaxis, it primarily involves ensuring proper procedures, appropriate induction sequence, and adequate airway protection. These measures protect us from the entry of acidic gastric content into the respiratory tract. This is one of the most dangerous complications in anesthesiology, with very negative prognosis. It can cause Mendelssohn syndrome, leading to severe pneumonia with acute respiratory disorder syndrome, and an inability to oxygenate the blood due to serious alveolar damage. In the past, it was believed that 25 milliliters of content with pH below 2.5 can lead to Mendelssohn syndrome. It is currently difficult to predict how much acidic content will actually cause lung damage. Besides following these procedures, there is also the possibility of pharmacological intervention. The primary method of pharmacological intervention is, of course, reducing the acidity of the stomach. This is done using proton pump inhibitors such as omeprazole and pantoprazole. Another important component in reducing stomach acidity is ranitidine. Ranitidine is very interesting. It is uncertain if it will return to the market. To be effective, it should be administered the evening before the procedure to have enough time to work. Of course, another dose should be given on the morning of the procedure. Another drug in this group is famotidine. It acts more strongly and quickly than ranitidine. At this point, it is also worth mentioning a drug that has been withdrawn due to its effect on CYP3A4. This is cimetidine, which has a similar effect to ranitidine and famotidine. Sodium citrate is perhaps the simplest method available. It involves drinking a certain amount of syrup that directly reduces the volume of gastric juice. This preparation is routinely used in pregnant women and is primarily associated with obstetric anesthesiology. However, it also has side effects as it increases the volume of gastric juice. It has been shown, though, that this does not increase the amount of aspiration if aspiration does occur. It is important to compensate for fluid loss. The average patient's daily fluid requirement is about 2,500 milliliters. Some of this is consumed with food, some as pure fluid. Due to fasting and the fact that the last meal for our patient schedule for surgery is several hours prior, it is important to remember rehydration or properly hydrating the patient. Imagine that if the patient normally requires 2,500 milliliters of fluid per day, they should receive at least uh, half of that, around 150 milliliters, in the 12 hours since dinner. We do not fully compensate for this volume to zero before surgery because intraoperative crystalloid infusion is also important, and we need to leave room for additional fluid administration. However, pre-surgery, this volume should be balanced using various possible preparation. In case of severe anemia or hemoglobin below 8, hemoglobin level should be also corrected before planned surgery.